Hello, everybody, and thank you for attending this presentation. My name is Saeed. I'm a member of CMR and data scientist at Novo Nordisk. Today, I will talk about a new approach to patients with history of clinical data, and its related AI models, which hopefully will be predict NASH from NAFLD in liver disease. I will explain why I'm trying to present this new source of model and why traditional models are not efficient, not in this disease, also other disease. I will talk a little bit about NASH, and why this disease is so important. Then I will talk about the objective of this project, why I started this project, and also what's the difference of the model in this project and other source of the model that we will always use for clinical data. Then I will talk about why this model works better, why our approach is better. And I will have a review on the database, data science, data analysis that I have in my data. And at the end, we will have a question and answer session, and we will discuss about this model. But what's NASH and NAFLD? NAFLD is a common liver disease. NAFLD is non-alcoholic fatty liver disease. It's very common in the population with a prevalence of 5% and common in liver disease. It's the prevalence between 40 to 70 in whole liver disease. So it's very important. NAFLD starts when the amount of fat in the liver cells exceeds more than 5%. It has some sorts of triggers such as type 2 diabetes, obesity, insulin resistance, metabolic syndrome, and comes with a series of comorbidities such as cardiovascular disease, chronic kidney disease, and apnea, polycystic ovarian disease, and a lot of other diseases. In the level of cell, when hepatic steatosis change to steatohepatitis, NASH is starts. And it's the time that we have inflammation, ballooning, cell injury in the level of the liver. And when fibrose added to this process, the liver goes to the cirrhosis phases, and the problem is extended in the whole liver and whole the body. In that, and cirrhosis almost ended to hepatocellular carcinoma, portal hypertension, cardiovascular disease, and at the end with death. So we see that how much is important, but the important thing is that the process from NAFLD to NASH is reversible, but from cirrhosis to the NASH is not reversible. So it's important that we detect NASH as soon as possible and start management and treatment for NASH. The management of cirrhosis is difficult with a lot of problem for clinician and also patient. For our data, for our model, we should consider some features. The most important ones are the risk factors. The NAFLD almost happens in the elderly patients, the patients with high fat diet, and the male more than female. Some races, such as Hispanic, is more common than other races, and also in black people is less than white people. The high-fat diet is considered as the most important factor in this problem. But changing from NAFLD to NASH has a source of triggers. The genetic triggers are the most important one, and considered as one of the triggers that can convert NAFLD and start NASH. Also, we have a series of comorbidities that I talked about, that like type 2 diabetes, obstructive sleep apnea, chronic kidney disease, cardiovascular disease, polycystic ovarian disease, that some of them, such as cardiovascular disease, could be start before, along, or after NASH or NAFLD. The important things about NASH is that we have no a simple screening test such as some of other diseases. For example, in chronic kidney disease, we can use GFR to classify patients' stage. But here we have not any simple test. But we have some sorts of criteria that we can be suspicious about the stages of the disease. The most important one is the metabolic syndrome, and it's the time that the patient has obesity, hyperglycemia, hypertension, dyslipidemia, and at least patient should have 4 or more criteria that we say that the patient has metabolic syndrome. As the function of the test of the liver is disturbed in this problem, we have a disturbed function test in the liver function test, and so we have increasing ALT, AST in NAFLD and NASH, also disturbing other tests such as ferritin, albumin, and in the latest version of some research, we have increasing nuclear antibody and some sorts of other antibodies. But as I mentioned, it's not the whole story. When the NASH is extended and to the fibrosis and cirrhosis, the other organs is disturbed, such as kidney, and we will have problems in kidneys such as increasing bilirubin, creatinine, and in hematology tests such as the neutropenia and disturbing prothrombin test that I didn't mention here. And in that case, the patients refer to a radiologist, and we will see increasing echogenicity in the ultrasound. But the only way to detect the patient's situation is to prove the NASH is biopsy. But biopsy is aggressive way. We can't do in all patients. It has a lot of side effect, and also we have the same problem in classification of fibrosis, again in biopsy. So based on, I think that this explanation, we can see that how much an automated AI model is efficient to detect NASH in the earliest stage. It's very important, and if we can develop this kind of models based on the history of the data, the flow of events that I will talk about, how much is important. But what's the objective of this project? Actually, I started this project by this object that I try to classify patients based on NAFLD and NASH. It was the first object that I started this part. In the second objective, I'm trying to a kind of predict NASH patients 1 or 2 months before starting NASH, in the time that we can do something for patient. A kind of prediction theory problem. At the end, we can generalize this model to other sorts of the disease, such as rare disease, and even we can use clinical trials that we have observed in the hospital and other place. And also, we will see that even this kind of models are important in other sources of the data, such as financial data, for example, commercial data, that we can use this view in other source of the data. But what's the goal of this project? As you see here, I have a real patient's data. In the future, I will actually have armed EMR that I can flag the patient's EMR data in the place that NAF changed to NASH. In that place, we see that the prognosis of the patient is going to be worse, and we flag the patient. The physician starts to manage the patient, and at the end we see that the prognosis is going to be better, and patient, we keep save the liver tissue by just management of the patient. It's the goal that we have at the end of the project. But for scoring the fibrosis in the patients, we have some sorts of non-invasive tests that almost all the clinicians use in the clinics and healthcare systems, such as APRI, FIB4, ELF, and a lot of commercial and academic tests. The important note is that some of tests, such as APRI, are that's a kind of ratio of AST over ALT, and FIB4, that is a combination of age, ALT, AST, and platelet, are more common than other tests. And also the radiologic tests techniques, such as ultrasound-based transient elastography measure, that is used for classification of fibrosis in this series of patients. But each test has own a kind of accuracy, kind of sensitivity and specificity. And tests are completely limited to the clinic and the clinician. None of them are not so accurate that we can compare with the biopsy of the patient. Now let's see that why the traditional models are not efficient in this series of patients and data. In the clinical data, we have a series of data such as a time series, irregular time series, fixed data, and so on. There is, as I mentioned, that patient starts with increasing ALT, AST, starts with increasing in ALT and AST, and after a while, for example, we check bilirubin and creatinine in the patients. So we have a completely irregular data in the patients. But in the traditional models, as we see here, we just use one number for each data. For example, age, sex, race, just one number or text. And for other tests, for example, for albumin or alkaline phosphatase, we just use the latest one, the median one, mean one, or the latest one. That is completely wrong, and we will see why. Let's categorize the patient's data in 3 stages. The static data, such as age, sex, and race, are just one number and one feature for each patient. But the second category that is more important is the dynamic data. The data such as lab test, vital sign, BMI. And as you see here, that here in this sorts of the data, this is a fixed data. This, you see that we have discontinued data here. Discontinued data here. We have other data here. And as you see here, that the data has not this, in the same regularity, granularity, in the same distance, in the same way of that other tests has. So if we consider just one number, for example, median, mean, and for or the latest one, you can consider a clinician, a doctor observed a patient for 2 years. And at the end, we just use the latest systolic pressure. It cannot be considered 2 things. First, that connection between the data, because, for example, the increasing bilirubin in the first stage can affect the, for example, albumin in the first stage can affect the bilirubin in the latest stage, or trend of the data. These are very important. That in traditional model, we don't consider none of them, just one number, and we lose the trend and, for example, some sorts of delayed correlation that we have in the features and lab tests. And also, we have unstructured data such as text, image, doctor's note, and other, that comes from other modality that we should consider inside our data with other modality that we have. So here you see 2 real patient that we have real data from 2 patients. The upper patient, as you see here, we have almost, this data is, comes from 2 years of the data from patients' database. You see that we have almost a continuous ALT, AST, and alkaline phosphatase for a patient, but completely discontinuous data for ferritin, or just 1 data or 3 data for glycerin, that we should consider for lab test in the patient. We cannot remove this data. The most of data scientists and others, when see that a data has a lot of empty point, just remove remove the data, the feature. It's not true. We should consider the connection between the data. As a sample for the patient I, as you see, we have a test from T1 to Tn. You see that in the time of I, the amount of the test T1 has a connection with the time J in the test Tk. And the same amount has another reaction, that delayed correlation, and other connection with test Tn. That we should consider this part of the problem in our test. The trend is very important that, as I talked, these 3 patients are observed with a clinician for 6 months as a management therapy. The goal is that decreasing the patient's ALT and AST to 30 and decreasing the weight 5 to 10%. If we just consider the latest amount, we completely mislead ourselves. Because why? The patient 1 has a decreasing trend, but the patients 2 and 3 has an increasing trend. So we should consider these trends inside the data. For the patient 1, we can continue with diet management, but for patient 3, we should change to a bariatric surgery, which is an aggressive source of treatment. Let's have a look at the data analysis. As most of the data that we see, I have completely imbalanced data. Just only 4% of the patients are NASH patients. You see here a distribution of the disease in the race. The Hispanic patients start NASH in earlier ages, such as 35, but in Caucasian, the upper ages, such as 45. It's different. But in both cases, as you see here, the distribution in NAFLD and NASH in my data is almost similar. But in distribution of the tests in NAFLD and NASH, there is the completely difference, but for example, in NAFLD and NASH in albumin, ALT, AST, and ferritin. For my model that I started with a kind of graph neural network, I consider a graph for each patient and connection as an edge and each test as a node for patient. I should start with at least some sorts of tests. So these tests are the tests that each patient should have in starting. The data is not complete data. Why? Because the NASH patient had the important problem in NASH and NAFLD patient is the weight. And we try to manage the weight. I saw that a lot of patients have a kind of weight consideration, not other sorts. So we see that how much is different the data and how much is irregular kind of data we have in the data. I tried to find a kind of correlation in the data and causality in the data to see that is there any correlation. It's not there, we can't see a complete correlation. I actually used a part of the data, maybe 10% of the data to show the correlation, but some correlation between ALT and AST, maybe white BC and platelet, but not clear correlation in the other source of the data. But why this model is useful? You know, in this model, I'm using a fixed data with using this a kind of fixed data with an irregular time series, a combination of two sources of the data. I don't summarize a long time series in the one just number. It's important. I'm consider trend, I'm consider connection between the data and delayed correlation and some sort of this kind of connection between the data. If we can detect NASH beforehand, before the biopsy, it's possible that we keep the most liver tissue. It helps to insurance company, healthcare company to decrease the cost. And as I mentioned, we can generalize to other sources of the disease that have a kind of configuration, such as I mentioned about the NASH. The last note is that we can use this model for similar models in financial data. In a stock market, for example, if you want to use a time series with fixed number of the data. I think that the slides is finished. Yeah, thank you for your attention. Let me know, please, if you have any questions. Thank you.